Thanks, Stephanie. Again, I have some relationship with everybody. Ultrasound is often the initial imaging modality for evaluation of renal disease, and non-enhanced ultrasound faces limitations in the assessment of focal renal masses and complex cysts. CUS in the kidney can overcome these shortcomings. And I mentioned that this morning that, the advantages of CUS, it's a real-time assessment of vascularity, they're true intravascular agents, no renal or liver impairment, short half-life, can use multiple injections, no ionizing radiation, the ability to subtract out background soft tissue, a contrast-only image, and we have a narrow ultrasound beam that allows for improved visualization of vascularity in small structures such as septations or small mural nodules. These agents are better tolerated than CT and MRI with fewer and less severe adverse effects and are not nephrotoxic and are safe for use in renal failure and renal obstruction. And we can use this to look at the microcirculation and quantify perfusion using a bubble destruction and reperfusion technique. Again, we talked about the disadvantages are somehow you're going to have to figure out how to get an IV started in your ultrasound department, and you need 2 pair of hands at least when you're doing the injection. And we talked about this morning all the large amount of data that you get, more so in livers than in kidneys, but you need to have some way that you can interface with your PACS and get the information there. I also mentioned that if you wanted to save larger data information for either reviewing or for research, you can buy a 4 terabyte USB drive and plug it into the ultrasound machine and store all your images there that you can retrieve them and then go over them again. So indeterminate renal masses are a common clinical problem. It is estimated that more than half of the patients over the age of 50 years old will have 1 renal mass, and many renal masses are found incidentally during an imaging examination. The majority of all these benign are benign simple cysts, which can be confidently diagnosed with cross-sectional imaging alone. If we exclude inflammatory masses and vascular anomalies and pseudotumors, most solid enhancing renal masses are malignant. Complicated cystic lesions with enhancing soft tissue components, excluding the actual cyst wall, are malignant. However, there was a wide range of complicated cysts between the obvious benign and the obvious malignant lesion. We use the Bosniak classification to characterize these complex cystic masses. Bosniak 1 is a simple cyst. Bosniak 2, minimally complex with single, thin, less than 1 millimeter septations and or thin calcified wall, well marginated, non-enhancing, high attenuation. Renal lesions are less than 3 centimeters are also included. Bosniak 2F, increased number of septa, minimally thickened or enhanced septa or walls or thick calcifications, hyperdense cysts greater than 3 centimeters with no enhancement. Bosniak 3, thick or multiple septations, mural nodules, and or hyperdense on CT, and Bosniak 4, solid vascular masses. If we look at the Bosniak score in the literature, you can see that Bosniak 1s basically have no probability of malignancy. The 2s are very small, and both the 1 and 2 usually do not require any follow-up. The 2Fs, which are a little bit more complicated, a 5% chance of malignancy, and are usually followed by monitoring. The Bosniak 3s in the literature are somewhere between 30 and 100%, turn out to be malignant lesions, so most institutions either biopsy or surgically resect these lesions, and the Bosniak 4s have about 100% chance, and these require surgical resection. And I put this here because we're going to talk about this same table after we go back through CEUS and see how CEUS fits into this table. So this is an off-label use of the contrast agent. The dose we use is maybe a little bit less than liver, and again, I think our standard dose is about 1/2 of the package dose. As the vendor equipment is getting better, the dose is dropping. We don't have to worry so much. We're not looking for washout, although it does occur in these masses. What's really important is just the enhancement. If we see enhancement in a lesion, it's very suggestive of a malignant lesion unless we exclude a couple benign lesions. And one of those is a renal pseudotumor or Hampton's hump. And CUS allows for accurate characterization of pseudotumors, such as fetal obulations in column number 10. The pseudotumor remains isoechoic to normal renal parenchyma in all phases of enhancement. As opposed to CT and MR, where there is excretion of contrast, we can see the medullary pyramids because they have less blood flow than the cortex. So we can see them on our standard exam. And if we see that the cortex is the same as the rest of the kidney, and we see a medullary pyramid, which is less vascular in the center of that, we can confidently call that a benign pseudotumor. Here's an example, and this is really a robust technique. So this image is actually from the late 1990s, and our results are the same. So this is an extremely robust technique. And again, here you're seeing a simple cyst with the solid arrows, no bubbles inside. And I have the dotted arrows showing you the medullary pyramids. You can see have less blood flow than the cortex. And you can also see with the dotted line that there's no excretion of contrast. So the renal pelvis and collecting system do not have any bubbles. So with the superior spatial and temporal resolution of CEUS, real-time imaging of the microcirculation allows resolution of flow within septa, nodules, and cyst walls that may not be visualized on color or power Doppler or contrast-enhanced CT and MR. Again, we're looking at sub-millimeter slice thicknesses with ultrasound versus probably 2.5 millimeter slices on CT and MR. So there's a lot of volume averaging, and if we're looking at something that's about a millimeter, that's very easy to get volume averaged on CT and MR. Excuse me. So CEUS has been shown to be superior to unenhanced ultrasound and contrast-enhanced CT in the diagnosis of malignancy in complex cystic renal lesions and may upstage the Bosniak classification. As I'll go through, I'll give you why I think that's true. So for solid focal renal masses, they're common, initially detected in ultrasound. And ultrasound has a low accuracy compared to CT and MR with considerable overlap between malignant and benign lesions. CUS allows a detailed assessment of the neoplastic circulation and is more sensitive than contrast-enhanced CT and MR in detecting vascularity and hypovascular lesions. So it's not uncommon for papillary cancers that don't enhance very much to be classified as complicated benign cysts on CT and MR. CUS is sensitive in identifying unenhanced cystic areas, necrosis, debris, as well as hemorrhage foci within the tumor. Here's a little clip. You can see there's this cystic lesion that's a little exophytic. And as the bubbles start coming in, we can see a border definition, but you can see that this lesion actually has several septations that are actually relatively thick and have little lobulations in them. And this is a renal, a cystic renal cell carcinoma. And as you can see there, even the cyst wall is a little bit more enhancing. Again, on CT and MR, this would be very difficult. And even on the B-mode image, I think a lot of you would not have suspected that all these septations were really there. So with persistent harassment by Stephanie, we looked at our first about 1,000 cases that we published in Radiology in 2014, and the study was to determine the utility of CUS in characterization of indeterminate renal masses. This was a retrospective study performed with our IRB approval, was HIPAA compliant, and they waived the informed consent. We had 721 patients referred for CEUS, with 1,018 indeterminate renal masses, and the study went from 1999 to 2010, identified initially on an imaging study. The patients were 44% female and 56% male, ranges of age from 17 to 95, and lesion size varied from 2 millimeters to 161 millimeters with an average of a little bit over 2.5 centimeters. So CUS enhancement patterns were used to characterize masses as benign or malignant. The lesion with a definitive diagnosis, meaning we had a biopsy, 306 of those, or 30%, were correlated with their CUS findings. 167 lesions were benign, and 139 of these lesions were malignant. Lesions without a pathological diagnosis which was 70% were followed up to 10 years, and now almost all of these lesions have been followed for up to 10 years. And this was the classification we used. No flow within the lesion's benign. Occasional bubble in septation. Sometimes you'll see a little bubble just mosey on through the septation. Those are benign. If we move down here, with constant flow of bubbles in a fine septation without nodularity, we had several of these cases, and again, we followed them for 10 years, and they all remained the same and didn't turn into malignancy, so we now consider that a benign finding. Enhancement equal to normal cortex on all phases with the presence of a central pyramid, again recognized by decreased flow compared to the cortex, a benign pseudotumor. Echogenic mass with enhancement less than renal cortex, often with a peripheral distribution, was benign and angiomyolipoma. So the fatty components of angiomyolipomas do not enhance. So it almost looks like some globular enhancement like you would see with a hemangioma in the liver. Again, we tried to send all these patients to confirm there's fat in the lesion by CT or MR, although our urologists don't think we have to do that. I think we probably should continue to do that. In comparison, if we had an echogenic mass with enhancement equal to or greater than normal cortex, sometimes with washout, that turned out to be a malignant renal cell carcinoma, and any other mass with blood flow, solid or cystic, was considered malignant. And again, we did not include any cysts that we thought were infected. So if patients came with pyelonephritis, we didn't look at those because most of those people are treated without going to an imaging study. And I'm going to see if I can get both of these going. So here we have two echogenic lesions. And just to show you, this echogenic lesion shows marked enhancement. There are some areas of necrosis inside and as a renal cell carcinoma, versus here in this angiomyolipoma, you can see there's much less enhancement than the normal cortex, although there is some flow within the lesion. So again, we actually do a reasonably good job in deciding something is an angiomyolipoma versus a cystic renal cell carcinoma, although I think they're in a fat-poor angiomyolipoma, we may interpret as a renal cell carcinoma, but we haven't had any of those in the study. So if we look at the results of our patients, and again, these are just the ones that we had confirmation of the diagnosis, sensitivity, 126 out of 126, so 100% sensitivity. Specificity, 132 out of 139, 95%. Positive predictive value of 95%, and really what's most important, we have a negative predictive value of 100%, meaning if we say something is benign, we're right 100% of the time, and again, we have now followed all those lesions for 10 years. So we think with additional prospective studies, it may be that if we do an ultrasound with contrast and see that the lesion does not have any flow, following the lesion every year, even if it's a Bosniak 3, may not be appropriate or not needed. The 5 false positive masses included 3 oncocytomas, so we're always going to call those malignant. In our institution, they're all either biopsied or come out because the pathologist actually won't read based on a biopsy if it's an oncocytoma or a renal cell carcinoma. And we had 2 Bosniak 3 cysts that had thick wall enhancement that turned out to be infected cysts. If we look at the per patient results, the 290 lesions that had at least a 3-year follow-up. Sensitivity, again, 100%. Specificity, 97%. Positive predictive value of 92%. And a negative predictive value of 100%. This slide is a little busy, but this is just to show you we had a wide range of pathology. And when you start out, you only need one of these cases for your urologist to decide CT is of no use. This was a 68-year-old male that came in for a renal stone protocol, so we have a CT without, portal venous phase and a delayed phase, and luckily for me, he had what appears to be a cystic lesion in the same slice, one on the right and one on the left kidney, to look identical on all phases on CT. However, when we do ultrasound contrast, the lesion on the right shows marked enhancement, more than normal renal cortex, and was a renal cell carcinoma, versus the one on the left that shows no enhancement and was a benign cyst. And it's very common, I think, for us to see the somewhat complicated, uniform, slight increased Hounsfield unit cysts that turn out to be papillary cancers on CT and MR, because you just can't see the enhancement, but we can see it actually reasonably well with ultrasound with contrast. Comparing MR with contrast, so the image on the left is a coronal MR image of a Bosniak 3 cyst with a solid component and septations. Do you think there's enhancement in those lesions or not? Even if I gave you the without image, I think you would struggle to be able to determine that. But if you look at the ultrasound contrast image on the right, you can see that what looks to be the solid component shows no enhancement and was a big hematoma at surgery. But if you look real close here, you can see the septations are enhancing, but there's little berries, little white dots hanging off all these septations, which turn out to be tumor nodules in the cystic renal cell carcinoma. And again, here's just an example. We've got 3 little bubbles going through a septation. We often see this. These turn out to be a benign finding. And again, I think one of the big applications here is this patient had a CT scan that had a little lumpy bumpy, but again, could not get a contrast study. Here you can see with ultrasound contrast, we can see this renal cell carcinoma that has marked enhancement compared to normal renal cortex and shows washout. So again, a very good application looking at these renal masses in patients that can't get contrast. Another complicated cyst with some calcifications on CT, can't get contrast. Here we've got the majority of this cystic lesion, shows no enhancement, but we have a very thick enhancing wall on one area. And again, this turned out to be a cystic renal cell carcinoma. Another case, again, CT scan without contrast with a funny looking kidney, and with contrast you can see that we've got the marked enhancement of this lesion. We can see the borders of the lesion well. We've got some central necrosis in the lesion. And again, you can notice again that we see the medullary pyramids having less blood flow than the cortex. Another case, MR without contrast, MR with contrast. Do you think there's enhancement of the septations? Really difficult to tell because of patient positioning changes, etc. But here is the ultrasound with contrast, and again, you can see enhancement of all the septations, and you can see all these enhancing white little berries hanging off here that are all tumor nodules. So very easy to make the diagnosis of cystic renal cell carcinoma. Another lesion, CT, unsure if this is solid or cystic. It looks like it could be solid on ultrasound without contrast, but after we give ultrasound contrast, the lesion has absolutely no blood flow, and this turned out to just be a large hemorrhagic cyst. I don't know what that is. So another clip, again, when we inject the contrast, we're going to see bubbles come in. The kidney usually enhances quite well. And again, we're looking at a lesion that's right here. And I don't know why it's playing so slow, but you can see that we've got enhancement, but a lot of areas that don't show enhancement. So again, this is a cystic renal cell carcinoma with areas of necrosis. So I just want to go back to that table I showed you about Bosniak classification. And if we look at our data another way, based on what we found, let's look at the Bosniak 3s. And again, we had classified those lesions based on whatever brought them to us, a CT with or without contrast, an MR without contrast or with contrast, or an ultrasound. And if you look at the Bosniak 3s, of those that were positive on CEUS, 96% of them turned out to be cancers and should have gone to surgical resection. But more importantly, out of the 300 and some lesions that we had, 275 of them were CEUS negative. So we could have saved almost 2/3 of the patient a biopsy or surgical resection because we were able to call them benign based on the CEUS. And even if we look at the Bosniak 4s, those that were CEUS positive, 98% of them turned out to be cancers. If we look, though, out of the about 150 cases, 56 of them showed no enhancement and were actually benign. So we could have saved about one-third of those patients interventional procedure. And interesting enough, we had one Bosniak 2 that actually showed enhancement and was a tumor, but again, that was only less than 1% because we had so many of those, only one. But I think looking at this, you can see we can markedly decrease the need for a lot of surgical procedures by calling these lesions benign with very high confidence. We do our RFAs with ultrasound contrast. It allows us to identify the renal mass. I think we can see the borders better. And again, as I mentioned this morning, immediate monitoring of the success of the ablation. So after we do the first ablation, we have our anesthesia people trained to inject. Usually we have to wait 3 or 4, maybe 5 minutes because the RF procedure itself creates some bubbles. We need to let them dissipate before we do the next injection. But we can do another injection and we can see how well we did. If there's residual tumor, we can guide the needle into those areas that have residual tumor. So we can be very sure when the patient leaves, we've been able to ablate all the tumor. And we use this for follow-up. Again, most of these patients, or many of these patients, have renal insufficiency. So here's a post-ablation. Can you tell me if there's any residual tumor? I think it's really hard. Even if we gave contrast, because of the background tissue, I think you'd be able to not be able to determine that. But if with CEUS, you can see this black hole was the renal cell carcinoma. So there's absolutely no one bubble in that area. So then we know that we did a complete ablation. This is just an example showing you a larger tumor that I ablated one portion, but you can see the increased enhancement here of the residual tumor that was not ablated. We can reposition the needles under ultrasound contrast, ablate this area, and like I said, although there is limits of injection of contrast in the package insert, I think in these cases it's very appropriate. If you need to do more to complete the procedure, it's actually fine to do that. And I mean, usually we don't have to give more than one vial, but if you have a large tumor or you're having difficulty with the ablation, you may have to use more. And I think in this case, it's clinically relevant that you give that dose. Renal infarction. High sensitivity in the diagnosis of renal perfusion defects because of its ability to image the microcirculation. An infarct appears as a wedge-shaped defect of enhancement in all phases. CEUS is more sensitive than color or power Doppler in depicting infarcts. And CEUS allows reliable distinction of ischemia from true infarction, as some flow can be demonstrated in cases of ischemia. Excellent for renal transplants, for looking for vascular complications, such as arterial or venous thrombosis, as well as infarction. CEUS is sensitive in the detection of active perirenal bleeding because of its high temporal resolution and real-time imaging, and quantitative analysis using low and high power techniques have been applied to transplant grafts, allowing functional indices derived from time intensity curves and perfusion from destruction reperfusion methods. I did delete. This was done on an ATL machine, so you realize this actually was done in the late 1990s. It was one of the first cases we did. It's a renal transplant patient that had an raising creatinine. He had a transplant renal artery stenosis. My partner did an angioplasty on that, but he noticed the blush when he was doing the angiogram. Patient had a CT with contrast and an MR with contrast that were normal. And at this point, I was driving everybody nuts to send patients for us to do in a study. And when we did this, we actually found this small, markedly enhancing lesion in the renal cortex. It only lasted for maybe 10 seconds before it became isodense, which is why you couldn't see it on CT and MR, a timing issue. We biopsied under ultrasound contrast. It was a renal cell carcinoma, and then we went ahead and ablated it with ultrasound contrast guidance. And again, here you can see post-ablation, there's no bubbles in the lesion. So again, you only need 1 or 2 of these cases for urologists to realize the significant improvement we can provide them in clinical care of their patients. For renal trauma, obviously CT is usually the modality of choice for abdominal trauma. CUS is more sensitive than B mode and almost as sensitive in CT in the detection of solid organ injury and blunt abdominal trauma. Lacerations, hematomas, contusions, and infarcts are seen in non-enhancing areas surrounded by normal enhancing parenchyma, and pseudoaneurysms and active bleeding can be diagnosed. And more importantly, this can be done at the bedside. So we wouldn't recommend this be the first modality that you use to look at a trauma patient. CT is obviously much more appropriate to do, but if you know a patient has a problem, a laceration of the kidney or spleen for that matter, to do the follow-up with ultrasound contrast is not an unreasonable thing to do, and many of these patients may be in the intensive care unit, and you can do that up there without having to move a patient with a lot of accessory poles down to the CT unit. This actually is one of our orthopedic surgeons who proves that after the age of 50 you should not play hockey. He got whacked and came in and had this CT that we were worried about having a problem. Here's the ultrasound without contrast. We see some signal, but again, after contrast, there's absolutely no bubbles, and this was just a traumatic hematoma with no underlying lesion, because our concern was, did he have an underlying renal cell carcinoma? So again, renal infection, usually there's no need for us to do an ultrasound with contrast and uncomplicated pyelonephritis. We usually don't even image these patients. They're usually treated without imaging. But CUS has a role to play as part of the assessment in patients with renal obstruction or impairment in whose CT and MR contrast could have potential deleterious effects on renal function when we're looking for an abscess. So focal pyelonephritis may be seen as a focal hypoechoic or echogenic area and may produce a mass-like lesion mimicking a tumor. The area may be hypovascular compared to adjacent normal kidney, and CUS can show an abscess or central defect with rim enhancement, which has a quick washout. So to conclude, ultrasound contrast has a high sensitivity of about 100% in our study and a specificity of 95%. Again, our misses were mostly oncocytomas and some infected cysts. Visualization of occasional bubbles or a constant flow of bubbles without nodularity and fine septations in cystic masses, a benign finding. And again, we've been able to distinguish angiomyolipomas from echogenic renal cell carcinomas with a pretty high accuracy just based on the enhancement pattern. The renal cell carcinomas being markedly enhancing, usually relatively uniform, angiomyolipomas not enhancing as much as the renal cortex and often having areas that don't enhance that are the fatty components. And again, I think the most important thing is that our negative predictive value is 100%. And if we get some large prospective studies that show this, I don't know that we need to follow these patients regardless of their Bosniak classification. And again, actually, there's now a committee. We're going to try to rewrite the Bosniak classification and include CUS in that. That may be out within a year. I don't know if we can make this fit into their classification, but it will definitely be added into a protocol on how to interpret these. So CUS can play an important role in renal mass characterization in patients with contraindications to CT or MR. And I would say even if they can get contrast, we often have much better results, particularly in papillary cancers. And this is our general, yes, it's safe and everything else slide. Any questions? So that's the Bosniak classification, and then the question is, how do you classify based on septations and nodularity? So if you look at the Bosniak classification, if there's a few septations that are very thin, that would be a Bosniak 2. If you start getting a little bit more solid components, that would be a Bosniak 2F. If it has much more nodularity or solid components, we'd call that a Bosniak 3. So it basically is just the amount of septations or nodularity or calcifications in the cyst. The more they are, the higher the Bosniak classification score. So renal artery stenosis, yes, you can use ultrasound contrast for evaluating this. You can look at this at the low MI technique to see the arteries, but you may want to do Doppler signals, right, and get actually look at the waveforms. You can use contrast with color Doppler. Obviously, you're using a high MA technique, so you may not be able to get a long period of time to see this, but we call this Doppler rescue. So if you're having a hard time, if you just slowly inject bubbles and like a very little constant flow of bubbles, you'll enhance the Doppler signal and it'll give you a better idea of where they are to do Doppler. So this may work out very well too in liver transplants or renal transplants where you may be having some problem. Some people actually will inject the bubbles into a 50 or 100 cc bag of saline and then slowly drip it in. So you always have like an inflow of bubbles that will enhance the Doppler signal. So that's one way of doing it. Using the low MI technique, you can look at the vessel, but you can't do Dopplers. So depending on what you're looking for, those are two options. Yes, it may, and again, we can look at the enhancement of the kidneys, and sometimes if you have a segmental artery, which you'll notice is the perfusion of the segment that's stenosed at a critical level, won't enhance as much as the normal kidney.
That was great, Richard. So you've just listened to really the expert on this topic. And for all of you in the audience, if you're not doing CEUS or you're starting, there is absolutely no doubt in my mind that as soon as urology, especially urology, gets an idea of what contrast-enhanced ultrasound contributes to renal mass characterization, they just really won't live without it. And it, I believe, forgive me, it's a little bit easier than the liver too. But it's a very, very great, really great application for CEUS. So now we're going to